Sciatica in the front of the leg? Pain, numbness, tingling, burning, shooting, all in the front of the leg. Everyone's talking about stuff in the back side of the body, but what about the front? In this video, I'm going to walk you through a step-by-step diagnostic mind map, flowchart, or tutorial so you can figure out the most likely source of your thigh pain, front of leg pain for free without needing an x-ray, an MRI, or waiting months to see a specialist. I am a specialist. My name is Dr. Charlie Johnson. I'm a physical therapist. I'm residency trained. I have a board specialty in orthopedics, and this knowledge and experience places me in the top 0.5% of PT specialists in the US alone. Let's dive into it. All right, so here we are, the complete diagnostic flowchart to help you figure out the most likely source of your front of the leg pain. Now, you might have some buttock pain, you might have some pain that goes down into the leg, maybe even into the foot, maybe even some back stuff. That is okay. Sometimes pain can be tricky and move around, but I'm gonna walk you step by step through all the self-movement tests you need to perform, all the signs, symptoms, and questions you need to ask yourself to figure out what the heck is going on. Right here, what you see is the most likely source of symptoms: pain, achiness, tightness, numbness, tingling, burning, shooting, any of that you're experiencing predominantly in the front of the thigh. Now, this is not an all-encompassing list. There are some other things I could have put in here, but because diagnostics occur in probabilities, I wanted to put the most likely things to try to keep this video as succinct as possible. So it could be a spinal problem. The L4 level, there are 5 levels in the lower back. The L just stands for lumbar. The 4th lumbar level, L4, is well known to refer pain or send signals of pain, numbness, tingling, burning, shooting to the front of the thigh. L5 can do it as well, to a little bit of a lesser extent, but it is on the possibility list. So it could be a spinal issue, disc, joint, nerve, something like that. Also, the sciatic nerve is comprised of the L4 and L5 nerve as well as others. So it's possible you could irritate the L4 nerve and experience sciatic-like symptoms in the front of the leg, not in the back of the leg per se. L4, L5 are possibilities. Maybe it's a sacroiliac, SI joint issue. Maybe it's a hip joint problem, hip osteoarthritis, labral tear, impingement. Maybe it's sensitivity of a wire or nerve on the front of the leg. Meralgia Parasthetica is what that's labeled as. We'll talk more about that. Or maybe it's not a body problem at all, but instead it's possible your brain is making a bit of a mistake. This is not made up. This is not all in your head, but it can create very real physical symptoms in the presence of being a bit sensitized. We'll talk more about that, as this is often overlooked. So we need to start moving through some tests to kind of narrow this down. First thing we need to do is start to wiggle the back to see if back is part of the problem or if hip or something else is. So I'm going to have you walk through some self-movement tests whereby you're going to bend backwards in 3 different kind of directions. Now, as you go throughout these back bend motions, I want you to ask yourself, is it painful? Does it increase or reproduce your pain, achiness, numbness, tingling, shooting, whatever you're coming to the video with? Or is it pain-free? Does it not increase the symptoms? So, back bend center, feet shoulder width apart, hands on hip, bend straight backwards. Is it painful or is it not? Just perform 1 or 2 reps. The second back bend is going to be a rotation extension, in this case to the left side, and then we'll do it to the right side. A 2-part test. So rotate to the left fully, and then bend straight backwards. Does this cause you pain or problems? Next, we're going to do it to the right. So you're going to rotate fully to the right first and then bend straight backwards. Is that rotation extension to that side painful or problematic? Let's talk about the likely scenario of it being painful first, and then we will go back and revisit what happens if it's pain-free. So what I want you to do, if 1 or 2 or all 3 of these were painful, then it tells us that it's most likely to be any of these things still. It doesn't really narrow it down yet, but we're going to do something super ninja here in a second. So as you bend backwards, you stress almost everything in this test. The joints of the spine, the joints of the pelvis, the SI joint, the hip joint as you load it and you move it into an extended position. Here you're loading the hip and you're putting it at the end of its motion in a backwards direction. You're also stretching the nerves in the front of the thigh, doing all types of stuff. So how are we going to get closer to the truth? We need to do further testing. So now we're going to do the same, bear with me, the same test, but in a slightly different way. And what I want you to do is I want you to take the side where you have most symptoms. Most people watching this will have symptoms on one side of the body. Now you might have symptoms on both sides of the body and both fronts of the leg, let's just say. We'll talk about that more in a moment. But either way, pick the side where your symptoms are and or where the majority of symptoms are, the left or the right side. If your symptoms are on the left side, I want you to take that symptomatic side and put that leg or put that foot up onto something. Changes the position of the hip. Put it on a stack of books, put it on a small box. I don't care what you put it on something, raise it up 4 to 6 inches. Then perform all the same back bends that we did over here. The only difference being that now the hip is in a slightly different position and the knee is a little bit bent. So back bend center, just 1 or 2 reps. Is it still painful or is it not? You might see that changes. We'll talk about what that means in a moment. Then rotate to the left and back bend. Rotation, extension to the left. Then twist your trunk all the way to the right, the left leg's still up, and bend straight backwards. What happens? Now, before we talk about what it means if it's painful or it's not painful, let's do the right side. So anybody has symptoms on their right leg, now you're just going to do just the opposite. Put your right leg up, prop it up on something, back bend center, rotate to the right, back bend, rotate to the left, and back bend. Now, talk about what this means in a second. Quick side note. If symptoms are both sided, it could be many different things. Chances are it's something central. It's affecting the either spinal cord or spinal canal or nerves very close to the center of the spine, such that you're getting symptoms on both sides of the body. Change this pink to blue. Picture this as a river. You have a river, the main river flowing, and things branch off. If you put a dam at the center of the river upstream, before the branch of the river occurs, you're going to get symptoms on both sides of the river. You're going to have water flow issues on both sides of the river. Same thing with the nervous system or even the blood supply system. If you pinch something centrally, you get symptoms on both sides. So it could be central canal spinal stenosis. It could be both-sided or what we call bilateral, lateral recess, or foraminal stenosis. A fancy way of saying you have holes where the nerves exit in the spine, they get closed off a bit. It could be an arterial problem, a blood supply problem, peripheral arterial disease. I've seen this enough to list it. It could be a medication-induced muscle pain, or maybe you have some muscle weakness too. Statins are often used to lower cholesterol. Statin-induced myalgia, muscle pain, or myopathy, weakness, things like that. Or again, your nervous system could create symptoms on both sides of the body, your brain. So if you're interested in learning more about both sided symptoms, check out another video I created that goes more in depth on them. So you've got the one-sided symptoms. If it was left, you did this. If it was right, you did this. We repeated that same darn test, just a little bit different. Why did we do that? Maybe now as you did it, it was pain-free. What does that mean? Or maybe it was still painful. Whether you did it with your leg straight or you did it with your foot propped up on something, it's still painful. Let's talk about that first, because pain-free leads back to kind of the same path down there that we'll talk about in a little bit. So it was painful. This tells us that it's most likely or more probable to be a back or a lower back joint issue, a pelvic joint issue, SI joint. So it could be L4, L5. It could be the SI joint. But it's very unlikely, if it's still painful, whenever you bent the knee, to be a hip joint problem or a problem with the tissue on the front side of the body. Now let me explain why so it's clear. You have a back bend here, your legs are straight. You have a back bend here, your leg was bent. We did these tests. The back position, in green here shown, is the same. The hip position is different, denoted by the yellow line. You can see in the bent knee scenario of the back bend, there is less tension as denoted by the squiggly yellow line on the front of the hip or thigh. And if you don't believe me, try tucking your shirt in, try bending back like this, see how much your shirt untucks, and then try bending backwards like this and see how much your shirt untucks. With your leg bent or your foot elevated on something, your shirt will untuck less versus here will untuck more, which tells us that there is less tension on the tissue in the front of the hip or thigh in the bent leg scenario. So if the result is the same, which it is because you're at this point in the flow chart, it's painful whether you're bending backwards or leg straight or bent, then it tells us it's a back problem, not a hip or thigh problem, because we manipulated or changed the hip or thigh position, and that doesn't matter. You still get the same result. It's painful, no matter what. We'll revisit this in a little bit. Keep in mind that if the bent knee now makes the back bend pain-free, it was painful when you did it with the leg straight, but then I bent the leg, Charlie, and now it's pain-free, then it tells us it's most likely to be a hip or thigh problem, not a back problem, because the hip or thigh position or tweak that we just made to the test does matter. It changes the result of the test. And again, we'll cruise down to this in a little bit, so stick around. Now that we know it's mostly a spine issue, or probably a spine issue, is it a nerve problem or is it not a nerve problem? So we're going to perform a nerve test, a nerve stretch test. We're going to perform something called a seated straight leg raise. So the seated straight leg raise test is a really good screening test to see if you have nerve sensitivity. This is the end position of the test that you see here. Start with your heel on the ground. Take your painful leg, heel on the ground, sitting on the edge of a chair or the edge of a couch or bench seat or something like that. Pulling your toes up slightly, then raise it up and raise it up slowly. And what happens? It's either going to be painful and restricted or limited, or it's not going to be painful. It's going to be pain-free. It's not going to make anything worse. So if it's painful and limited, let's talk about that. But in a moment, we'll talk about what happens if it's pain-free. So if it's painful and limited, then this points to symptoms being of nerve in origin. You have nerve pain. We call this fancy term radicular pain. Versus, as you'll learn here in a moment, if it's pain-free, then we can be 95% or more sure, because this test is so darn good at tugging on the nerves, that you do not have nerve pain. We call this referred pain from some other structure than the nerve itself. Okay, so let's go through this one first. Now, this is not super common, but either way, radicular pain is often described as shooting, burning, numbness, tingling, electric, jolting. Usually it's in a narrow band. You can kind of trace it going down your leg. Cut my leg off type pain. This stuff is seriously painful. It's not as common as referred pain, but can still occur. So now what I want you to do to further differentiate between, well, is it L4 or is it L5 nerve? Well, we can figure that out, or we can get closer to figuring that out. I want you to perform something I call the belly knee bend test. So you're going to lay down on your belly. I would put like a very thin pillow or a very thin towel underneath your pelvis just to remove some of the tension. And then I want you to, laying on your belly, slowly bend your knee as if you're trying to touch your heel to your butt. Now, a quick fatal flaw. Be careful not to arch your lower back. If you have stiffness in the front of your thigh as you're bending your knee and activating your hamstrings to do so, you may find yourself arching your back. This will muddy the results of the test. So it helps if you put a little pillow underneath your pelvis, just a small thin one, not a big one. Bend the knee up. As soon as you notice your back starting to arch, you can stop. Or if you're having trouble not bending your back or not arching your back when you do this, have somebody else do it for you. Very slowly bend that leg up, again, as if you're trying to touch your heel to your butt. And we want to see what happens. Something's going to happen. It's either, again, going to be painful or it's going to be pain-free. So if you have a painful straight leg raise test, and we know you do because you're at this point in the flowchart, and a painful belly knee bend test, then this tells us it's more likely than not an L4 nerve problem. Now, how can we be so sure? Well, it just makes sense. The L4 nerve is common between both the sciatic nerve, which is stressed during this straight leg raise test, and the femoral nerve, the nerve that goes down the front of the thigh. And therefore, if both tests are positive, it tells us that the common nerve root, the only one that's common, the L4 nerve, is the most likely cause. On the other hand, if the straight leg raise was positive, which strains all these nerves, L4, L5, S1, S2, S3, but this test, which only stresses the L2, L3, L4, the belly knee bend test, is negative and or pain-free, painful straight leg raise, pain-free belly knee bend test, then it must not be the L4. Because the L4 was involved, it would be painful, but it's not. So it must be the L5 or the S1, the S2 or S3. Now keep in mind while you're watching this video, because you have symptoms on the front of the leg. We'll talk about why it's not the S1, it's not the S2, it's not the S3. We'll get to that in a moment. So the L4 nerve, let's assume both of these were painful. Not very common, but it can occur. You can see here from some of the pain drawings, most of the pain occurs in the front of the thigh. Sometimes it can be felt in the back of the thigh as well, but predominantly or more so in the front of the thigh. So if you had to say right off the bat, what is the likelihood that someone with front of the thigh pain has an L4 or L5 nerve problem? You'd say L4 all day. Now let's test the function of the L4 nerve, because we can get even more specific. Now we can talk about, well, what kind of nerve issue do we have? So I want you to perform a strength test, which is going to test the muscles supplied by the L4 nerve, the quad or the thigh muscles. We're going to do a single leg sit to stand. You can hold on to something if you need to. Just try not to use it to pull up. You're really trying to measure the strength of your ability to sit to stand. If you need a little bit of a higher seat, you can do that, put a pillow or a cushion or something like that. You're going to do as many sit to stands as you can, within reason, on the pain-free side, followed by the painful side where you have the symptoms. And if you find that very clearly, we're not talking like a couple reps different. We're talking like, man, I can't do it on that side, but I can do it on that side. And there's a very clear difference in the strength, and we're going to call that weak. And this tells us that your nerve is not functioning very well. It's unhealthy. This would be classified most likely as L4 radiculopathy. Radiculopathy being defined as objective, meaning not what you think or feel. I feel weak. Like, hey, you actually are weak when you go to test it. Motor, so muscle strength loss, or loss of feeling. When I go touch the front of my thigh, Charlie, I can't feel it. I can poke it with things, and I can feel it on my one side, and I can't feel it on the other. So there's some sensory tests involved that we could do as well. But either way, this would be a clear sign that you have L4 radiculopathy. The nerve appears to be, at the moment, damaged or not getting all the signals through that it should. But if it's strong, then it's not that it doesn't stink, it's not that it doesn't hurt, it's just that now you have L4 radicular and or just straight nerve pain. So you have an angry nerve. The nerve is functioning. All the lanes on the highway that transmit feeling and movement potential are okay. It just hurts. So that's L4 nerve. Maybe you have an L5 nerve issue. This is much more common when it comes to nerve issues in the lower spine. But as you can see here, it doesn't commonly send signals to the front of the thigh. So that being said, if there are no symptoms in the back of the leg, yeah, you're here because you've got symptoms in the front of the leg. But if there are no symptoms in the back of the leg, then the probability of an L5 nerve problem goes way, way down. It's probably L4. We can test also the strength of the muscles that are plugged in by the L5 nerve, the muscles of the shin, the muscles of some of the toes. So we're going to go perform heel walking. I wanted to try walking on your heels. You can do this either in place or try to walk around the room. And if one foot is slapping, the painful side is slapping, foot drop we call this, and the other side is fine, again, this should be a clear difference, then we're going to call it weak, and you would have L5 radiculopathy. If it's strong, heel walking passes the test, you're okay, side to side, L5 radicular nerve pain, angry nerve, L5 nerve. Now, S1, why didn't we talk about that? S1, nerve problems almost never send signals to the front of the thigh. That's why. So let's go back. Where were we? We were here. Painful and limited straight leg raise test. I promised you would talk about, well, what if the leg raise test was pain-free? We mentioned earlier that the test is really darn good. So it's not nerve pain. You don't have sciatic-like symptoms in the front of the thigh. You don't have nerve symptoms at all. You more likely than not have what we call referred pain from, again, a structure other than the nerve. So this could be the joint, the discs, ligaments, things like that. L4 is the most likely cause because L4 is most known to refer symptoms to the front of the leg. Could be L5 though. Could also be the SI joint. Most people with SI joint pain also have buttock pain and sometimes front of the leg pain, sometimes groin pain, mostly buttock pain, but again, it's still a possibility, so I wanted to keep it in here. And the difference between radiating pain, radicular pain, is that the nerve stuff is shooting, burning, electric. This stuff is deep, dull, achy, hard to pinpoint. It kind of just hurts in this area. And I'm going to delineate now by age. So nothing against age, but if you are greater than 50 years old, we've done studies that show that joint problems, degenerative joint issues, so facet joint problems, the joints in your lower back, arthritic issues are much more common. Disc problems, soft tissue issues are a little bit less common. It's not that they can't happen, it's just that they're less probable. So now we're talking, given your age, that it's more likely to be a joint problem at the L4 level, L5 level, and SI joint issue, or again, a sensitive central nervous system. So L4, L5. How do we tell if it's a joint problem in your lower back? Well, we've done some studies, and we find there are clusters of findings within folks who respond positively to treatment or blocking of the joint. So we go in, we block the joint with some type of numbing agent and or steroid, and then we see, those who got relief, which indicates that it's maybe a joint problem, what do they have in common? Well, they had back pain. Folks with joint problems in the low back almost always have pain just off the side of the spine at the level that is the issue. L4 is going to be a little higher than L5. They might also have buttock pain and or front of the thigh pain. The SI joint, as you'll learn here in a little bit, does not cause pain above the belt line or is not known to refer pain above the belt line. It could be like right on the belt line, but it's almost always just below. And again, it can refer to the front of the thigh as well. So let's keep clearing this up. Pain is often if you have an L4, L5 joint problem in the lower back, better while walking or sitting. Not that that's super helpful, but this is helpful. There is no pain when getting up from sitting. We'll talk about this in a moment to compare and contrast some things. Coughing, sneezing, and straining does not cause an issue. Coughing and sneezing and straining does cause an issue in most cases of disc problems. There is no transitional pain though. And of the back bends, which would be most yucky, you almost always find if your symptoms are on your right, that rotating and extending to that painful side will be the most painful of the back bends. If it's to the left, rotating, extending to the left will be most painful because you're closing down or clamping down on those joints, causing referred pain. Now, let's just say it's not a facet joint problem. Maybe it's an SI joint problem. I want you to perform 2 self-movement tests, both designed to provoke the SI joint to cause some type of shear and or irritation to the joint. So do these with caution. First one, a self-thigh thrust test. Someone could do this to you, or you could try to perform it yourself as indicated here. Take the painful side, bend the knee up just above 90 degrees. Attempt to push that thigh as if trying to push the hip joint down into the floor. Is it painful or is it not? Now you're going to do a single leg bridge maneuver. So take the painful leg, put it on the ground, and push on up. You'll lift your buttock up, and it'll look like this. I'm also actually going to recommend you do it on the other side as well. So do this on both sides. And take your non-painful leg, put that down, and perform a single leg bridge on that side as well. If the thigh thrust test and the single leg bridge test, either of them, regardless of which side the symptoms are on, reproduced your symptoms in the groin, maybe side of the hip, thigh, and they're both positive, painful, then this points to an SI joint problem. If not, maybe it's not as structural as you think. So let's just say it is an SI joint problem, or we're at this point in the flow chart. SI joint issues are more common, yes, in people who are greater than 50 years old, with the caveat or exception to folks who are pre and or postpartum. So younger females, as there's a hormone called relaxin, which is secreted during pregnancy to ease the pelvis for childbirth. And you'll see sometimes it causes, for lack of better terms, instability or ligament sensitivity issues around the SI joint. The primary location of pain for folks with SI joint problems will be the buttock, so one-sided buttock pain, but again, it can cause pain in the front of the thigh or in the front of the leg. So most commonly, you'll see it, people point to this one spot. We call this a Fortin finger sign. There's a little dimple there. If you can see it, awesome. If you can't, maybe you can feel it. Either way, this is the very common location of the symptoms, one-sided, just below the level of the belt line. You can see here, I worked with a gentleman named Scott who had SI joint issues for years until we helped him resolve it. As we mentioned or alluded to earlier, there is no pain above the belt line, no back pain. That's where you start to get into more facet joint problems. So you can see here, facet joint stuff. Yeah, maybe you have some stuff in the front of the thigh, but SI joint problems do not refer above the belt line or are not well known to. Was there a fall or accident? The SI joint is questionable with regards to how much it moves. Some people say it's immobile. It's pretty much kind of fixed in the pelvis, like a keystone, if you will, is fixed in an arch. So oftentimes, trauma is required to cause this. So was there a fall or accident that caused your symptoms to start? Is there pain going from sitting to standing? The reason that I emphasize this is because, remember, this is another distinguishing sort of element or variable. There is no pain when going from sitting to standing in most cases for people who have facet joint problems. But for people who have SI joint problems, you often do get transitional pain. There's often pain rolling over in bed. If you think about it, that looks a heck of a lot like, where is it? This single leg bridge test. When you roll on over, maybe you don't look like that, but you got to push off the one leg. So it makes sense that rolling over or trying to push off would be problematic. And because it's a joint, you have no numbness, burning, tingling, stuff like that. SI joint issues. And again, if you said, hey, I got this far and these tests were not positive, then it's possible it's a central nervous system sensitivity issue. We'll talk about that more just at the very end. Cool. So let's go back. Facet joint problems, age greater than 50. What about if you're less than 50? All right, so you have a pain-free straight leg raise test. It's not nerve pain. We talked about joint. We talked about some SI joint ligaments, some things like that. But now you're younger. Well, the younger you are, the higher the probability becomes more soft tissue related. L4 disc, L5 disc. Remember I said that as you get older, the joint problems become more prominent, with the exception of SI joint if you are pre or postpartum, a younger female. That could also be in the deck of cards then. But those things are lower on the probability list, so it's more likely to be a disc issue. So now what type of disc issue? We're not really going to be able to differentiate between L4 or L5 per se, although L4 disc is more likely to refer to the front of the leg than the L5 disc, which is more buttock and back of the leg. So location alone does matter. But it's possible you have a mild herniation, It's possible you have something more severe, a large disc protrusion or herniation, disc extrusion, disc sequestration. So what's going on? If you have a mild herniation, then chances are you have central or one-sided lower back pain along the level of the belt line. It may shift from right to left, in addition to the front of the thigh pain. Chances are you have trouble straightening or standing up after sitting, so you have transitional pain. Disc issues cause trouble when going from a sitting to standing position in many cases. Transitional issues. Guess what? So do SI joint problems. But so do not, if that makes any sense, facet joint problems. No pain. So, little differences here, which can help you figure out what's going on. Pain is often worse first thing in the morning because disc pressure is highest first thing in the morning. Pain is often worse while sitting, driving, bending, lifting, anything that puts you in the C-shaped position. Pain may be better when you're walking, standing, or lying down. There's often this roller coaster of back pain within this story. Back went out, it got better. Then back goes out again, and then it got better. And it seems like every time the back goes out, it just gets worse, and now you have leg pain. Disc herniations are almost always one-sided. There is a ligament here, the posterior longitudinal ligament. There's a ligament here that acts sort of like a barrier, if you will. And so the disc hits it, goes out to one side. If it's right-sided, and you are going to have some type of lateral shift, that's a telltale sign of a disc herniation, you'll almost always be shifted away from it. Sometimes towards, but oftentimes away. If it's left-sided, then you will often be shifted, again, away from it as the body tries to get away from the painful lesion or issue in the spine. Disc issues. Mild herniation. What if it's something worse? How does that present? People with large disc herniations, extrusions, sequestrations of either the L4 or L5 will almost always feel better when they're unloaded. So lying down and decompressing is going to feel best. Pain may often feel better if they're sitting or bent forward or even reclined, again, unloading. Pain is almost always worse when they are loaded, when gravity takes effect and you're walking or standing. Almost without a doubt, if you have a clear yucky back bend, just a back bend center, and you do have a disc problem, it's probably larger and within the realm of one of these. Contrary to what a lot of people believe, back bending can make many discs worse, and bending forward can make many of them better, right? This is why we don't treat the picture, we treat you as a person. So here's imaging evidence. This is imaging evidence of a disc protrusion getting bigger. You can see here, it's bigger, that black little bulge right there, when someone bends backwards. That same person, the disc gets smaller when they bend forward. Pretty cool. Not to mention, if you have a large disc herniation, you are taking up space in the spine where the nerves travel. And then when you bend backwards, because you should be doing all these cobras or press-ups, right? You're actually making the holes even smaller than they already are. This can compromise the nerve even further and make you worse. Bending forward may actually create some breathing room and gap that area. And it's possible you may be shifted as well. Cool. So, brain, we'll talk about that at the end. All right. Where were we? Referred pain, radiating pain, leg raises, back here. Here we go. Let's just say you are one of those people where you did this first step, the back bends with the leg straight, and you were like, ouch, that's painful, but that doesn't really help me. And then I went here and you know what? I did it. And now with my knee bent, my hip in a different position, I am pain-free. It is pain-free. Well, remember we talked about up here in the explanation of things. If the bent knee makes the back bend now pain-free, it was painful here, but then when I bend the knee and I take tension off the front of the thigh and I deload a bit of the hip, I change the hip position, then this indicates it's more likely to be a hip and or tissue issue on the front of the thigh. So here we are. It tells us it's not your back. So if bending straight backwards was pain-free to start, or it was painful, but then moving the hip now made it pain-free, boom, you're here. Not a back issue, or very unlikely to be a back issue, much more likely to be a hip joint problem or a tissue issue on the front of the thigh, a nerve problem that we call Meralgia Parasthetica. Or we've still got this brain versus body possibility that we'll have to talk about. So now we're going to do the figure 4 stretch test. I want you to see how well the hip moves when you do it, how much motion you have in the hip, and again, what symptoms you experience. And one of two things are going to happen. It's either going to be painful or it's going to be pain-free. It's not going to reproduce or make your symptoms worse. In which case, it tells us more clearly what's going on. So let's just say it is painful. Chances are then that you have a hip osteoarthritic and or hip labral issue. Or we could say a problem within the hip joint. Something within the hip joint is causing it to be painful, that figure 4 motion. But the probability that it is a nerve problem in the front of your hip, Meralgia Parasthetica, goes way down. And it kind of makes sense because as you bring your knee towards your chest, you take some tension off the front of your hip. In fact, you slacken the front of your hip. And nerves don't like to be stretched. They're generally okay being slackened. So it reduces the probability that it's Meralgia Parasthetica and really increases the probability that it's a hip joint issue. Still could be brain instead of body. Now, when you did it, remember I said, I want you to take note of the range of motion as well as what you feel. So it's painful, but is it stiff or is it loose? So is it stiff, whereby when you do the test, not only is it painful, but the knee on the painful symptomatic side sticks up in the air? Or does the knee on the painful side go further towards the floor? Do you have more motion on the painful side, or is it pretty darn symmetrical? We'll call this loose. They mean different things and point to different issues. Now we're going to segment by age again. So if you're greater than 50 years old, chances are very high if you've made it this far that you have hip osteoarthritis. Let's talk about what that presents as. Generally, females are more likely to have it than males, although many males have it as well. Oftentimes, as symptoms progress, you'll have trouble sleeping, getting comfortable. There will be difficulty for sure putting on socks, shoes, cutting toenails. Why? Because that figure 4 motion is your ability to put on your socks and your shoes and cut your toenails. So all of those things will be problematic and painful. You can see location of symptoms. Most people feel pain in the front of the thigh, the groin. A lot of people feel pain also in the butt. Many people feel in the thigh and also in the knee. There are many cases of people who just have knee pain, and you find out that it's their hip after they had their knee replaced, of course. Maybe shin, even the ankle. And so this can create a pseudo sciatica, but it may be a hip joint problem causing all of it. The butt, the outer of the hip, the bursitis pain, the thigh pain, the knee pain. Fix the hip, everything goes away. You can see here in the pictures, there's a loss or a narrowing of the joint space. This is normal. This is loss or narrowing of it. Pain with climbing stairs, loading the joint. Morning stiffness, that maybe gets a little bit better as you walk it off. There's generally a gradual onset of symptoms. Progressively gets worse over time. And the pain and stiffness getting up from a sitting position or out of the car is noticeable. And again, maybe you can walk it off if you're in the early stage. But oftentimes what you'll find, people come to me when they're in the end stage. They're saying, Charlie, that used to happen, but now I'm limping. The further I walk, the more I limp. The more I do, the more I limp. You may have noticed that when you did that back bend test, this is why we had you bend the knee, that you felt pulling or pain, and you would have said, yeah, the back bend test is positive. And I'm going to say, well, it's kind of a false positive. It's not your back. It's actually because that motion extends your hip. And if you've got a yucky hip, you've lost motion into extension, which is going to cause you sensitivity, and it's going to make it look like that's positive. But when we bend the leg up and we deload the hip, now all of a sudden it's magically not. It's not your back, it's your hip. Okay? It's possible you have a little bit of a wobbly walk, whereby when you put load through the one leg, you do this. We call it a Trendelenburg gait. Maybe somebody's pointed it out to you. Maybe you've noticed yourself if you walked, you've seen yourself in a window or in a mirror that you kind of teeter-totter side to side. Hip weakness caused by pain, limitation in the hip joint itself. Now let's just say that you still have a stiff and painful hip, but you're less than 50 years old. Hip osteoarthritis goes down a bit, but it is possible you have some type of hip impingement or hip labral tear, traumatic or maybe just degenerative, but either way, these are the signs and symptoms. Again, there's a pinchy, painful feeling in the groin. People with osteoarthritis will also have this motion that's painful, but definitely we call it a fader position, flexion, bringing your hip up, adduction, kind of pulling it in a little bit, and then rotating it in or kicking your lower leg out. And this will cause a pinch in the hip. You'll say, ouch, Charlie, that really hurts. And you can see here. So if we zoom in, this would be a normal head of the femur and then the hip socket. This right here, you can see some what we call bony overgrowth. We call this a cam impingement. So there's different types of hip impingement, things that can cause, when you're moving your hip, tearing or irritation of the labrum. You can see here that there's not too much of a lip, a little bit, but it's more of like a hook, like an icicle coming off the socket of the hip joint. We call that a pincer impingement. And here, well, it's a very shallow socket. We call that hip dysplasia. Okay, so again, hip dysplasia, I didn't put it on this list, but it is possible that you get some groin kind of front of the thigh stuff with that as well, but just lower on the prevalence or possibility list. All right, so we go back. We did this figure 4 stretch test. It was painful. Hip joint problem? Probably. We went through stiff. Let's talk about loose.
Charlie, you know what? I did that test, but my painful side actually moves more than my pain-free side. Or it moves the same. It's not stiff. It feels stiff, but it's actually objectively not. Chances are it's not an osteoarthritic hip joint restriction there. Instead, more of labral tear like symptom. So it's possible with a labral tear that you still have preserved motion, but you have this pinchy feeling in the groin with the tests that we already talked about and the images we already showed. That could be the most likely cause. Okay? Or again, it's possible that why do I have all this motion? And yeah, it's painful when I do that, but nothing's restricting my motion. Is it actually physical? Cool. Okay, so went through the figure 4 stretch test. Painful. We talked about that. What if it was pain-free? Well, if it was pain-free, well, we already know at this point in the flow chart, it's most likely not an L4, L5 spine problem, most likely not a pelvic SI joint problem. And if this motion, your ability to move the hip, was not painful and doesn't reproduce your symptoms in the front of the leg or side of the hip or buttock or whatever, then probably not hip osteoarthritis or labral tear. So now we're increasing the likelihood that it's a nerve issue or some other issue with the tissue on the front side of the body. We're going to list this as Meralgia Parasthetica as one of the more probable causes. So, talk about that. Meralgia Parasthetica, and then we're going to talk about brain versus body, by the way. Okay. Interesting nerve. So, L2, L3 comes off, and we have this lateral femoral cutaneous nerve. If you want, you can look it up. Either way, it's a nerve. And it goes superficially, meaning just beneath the skin, right in front of the point of your hip. So if you take your hands, put them on the front of your hip, you'll feel little points, little hip bones there. And you also have a ligament that goes from that hip point to another point on your pelvis, a little what we call tubercle or a little bit of a bony growth on the front of your pelvis. It attaches and connects that. We call that the inguinal ligament. Not that you care that much, but maybe you do. And this is the site of compression or irritation. Now, what's interesting is that this nerve is only a sensory nerve, meaning it only has a path for feeling. So if you snip this nerve, you will not lose your ability for any muscles to function. All your muscles will function perfectly fine. You will just lose feeling in the skin in this area of the outer kind of front of thigh. You won't notice any symptoms below the level of the knee because this nerve supplies only feeling to this area of the thigh above the level of the knee. So again, if you snip this nerve or irritate this nerve, it's a sensory-only type of experience that you'll have versus if you were to snip the L4 nerve, then you're going to lose feeling to this area and lose function of your thighs and things like that because that has both feeling and movement fibers that travel through it. Now, what I want you to do to further differentiate and make sure, just double check so you get the concept here, that we're on the right path, is to go back and do this strength test. So you've probably done this already, potentially, but if not, let's do it again. Single leg sit to stand. Do it on your painful side where you have symptoms versus the pain-free. Do as many as you can on the pain-free, then see what you got on the painful side. If it's clearly weak, like, hey, I could do a lot on that side, I could barely do any on this side, then this is not consistent for the reasons we just talked about with Meralgia Parasthetica. If you have weakness, well, then that points to it being more of an L4 or spinal nerve root problem. So go back. If you missed it, go back up to the spinal stuff and recheck to make sure there's nothing goofy there that you overlooked. If you're strong, this increases the probability. We shouldn't expect to see any weakness with Meralgia Parasthetica. Now I want you to do another test. If this nerve in the front of the thigh is sensitive, well, when you stretch it, when you compress it at this area, you should see some reproduction of the symptoms. Makes sense. So if your symptoms are on your left, you do it on your left. If your symptoms are on your right thigh, you do it on your right. Do this slowly because it is a nerve. All right. So what you're going to do is you're going to start like this. If you need to hold on to something for balance, you can. But start with a fully flexed or maximally flexed knee. Again, do what you can within comfort. Then what I want you to do is I want you to kind of take that knee, keeping the knee bent. I want you to take that knee and take that hip and arc it backwards so you're tensioning that nerve. And if this nerve is sensitized, that this will recreate your pain, numbness, tingling in the front of the thigh. If Meralgia Parasthetica is not the problem, then you'll be able to do this, and it will not be an issue. Keep in mind, an L4 nerve problem will cause you issues here, which is why we covered that first. Look at this, and then look at this. They look very similar, don't they? So this is why we rule this out first. Rule out upstream first. Upstream problems can cause downstream effects. You want to start upstream. Pain refers downstream, not upstream. So That's why we did that first. So at this point, again, if it's on the right, do the same thing. You'll get some sensation, some funkiness in the thigh. Because, again, how close it is to this area, any type of compression, in this case, compression via stretch, via this nerve stretch test, or obesity, being a bit overweight, wearing tight clothing or belts. The classic example is a police officer, or maybe like a prison guard or something like that, where they have all this stuff weighing them down. Maybe an electrician, a plumber, somebody who wears a belt of tools, right, that's causing issues there. Tapping or rubbing just at that point of the hips can often send some type of twinkles or sparkles into that area on the front of the thigh. Prolonged sitting, whereby you're pinching it off, another form of compression, can also cause an issue if you're reducing what I call the hip trunk angle by sitting like this, leaning in to do stuff, work, whatever it may be, or sitting in bucket seats whereby the knee is higher than the level of the hip. You can see issues with that as well. That is Meralgia Parasthetica. All right, so you've made it this far. The only thing we didn't talk about is this brain versus body. Why have I been holding off on this? All of this stuff is what we've discussed so far. Lots of different things within the body whereby the pain that you're experiencing is due to damage of the L4 disc joint nerve, something like that, L5, SI joint, hip joint, nerve to the front of the thigh, and probably some other things that we mentioned. But one thing you must understand is that the brain can also create very real physical pain, symptom, sensations anywhere in the body, including in one front of the thigh, in both fronts of the thighs, in both shoulders, in the neck, anywhere in the body. So what you must know is that your brain can create real pain. Again, I say that over and over again because many comments are to potentially come saying this guy is saying that I'm making this up, and I'm not saying that. You're saying that. The brain can, a sensitive central nervous system, we call it central sensitization, can mimic any of these physical issues with the body. So how do we differentiate now between the two? If you're at this point, you're like, nothing really added up. Well, let's talk about it. Answer these questions such that you can start to build some evidence for yourself for or against it being a problem with the body or the brain. So 13 questions. Based off the number of questions you either answer yes or no to, go ahead, write yes or no to these questions. That determines the likelihood that your symptoms are more structural of the body or centrally of the brain. So, are you unsure as to why your pain began? Meaning, did you just start having pain out of the blue? Or you think you know what caused it, but you don't actually know? I mean, let's be honest. If you hit your finger with a hammer and your finger hurts, which it will, you don't have to guess what happened there. If you break a bone, most people don't have to guess what caused them to have a broken bone. It should be pretty clear. When you damage something in the body, the response is immediate and then often lasting as well. So if you're not sure what caused it, or you're playing guessing games, you're going to say, yes, I am unsure. Question number 2, is your pain chronic? Greater than 3 to 6 months in length. We know the body, most tissues in the body, heal within this 3 to 6 month time frame. If you break a bone, 3 months, 8 to 12 weeks. If you rupture a disc, most people, 75% of people, will feel pretty darn well at around 6 months. So you start to get symptoms that are 8 months, 9 months, a year, things like that, and this becomes something where you start to question, well, why did the body not heal? So is your pain chronic? So if your pain is chronic, then you're going to say yes again. Did your pain begin during or around a time of fight or flight, good or bad stress? Some people will say, hey, it was the best time of my life. I just had a baby. I don't know about you, but I had one baby and it was really difficult. Meaning, I didn't even have the baby. I'm just the dad to the baby, right? And she's the best thing in the world, but it is really challenging to be a parent, okay? And so that is good stress, I guess you could say, but still it puts us in a fight or flight response. It could be financial, it could be relationship, it could be career. You just got a new job, or you just lost a job, significant financial changes, death, birth, whatever. Did it begin, think about it, during or around a time of fight or flight? Is your pain inconsistent? Some good or bad days. I was doing great yesterday and today I had a terrible day and I don't know why. If so, yes. If it's constant then and not inconsistent, then no. Does stress trigger your pain? When I feel more stressed out at work, at home, in life, whatever, good or bad, do your symptoms increase? If so, yes. If not, no. Do you experience relief of your pain with distraction? Do you notice that if you go on vacation, or if you're focused on something else, or you get lost in your work, or you're doing something you love, or you're out with your girlfriends or your boyfriends or whatever, and you're engaged in something else, you're preoccupied by something else, that you don't notice your pain as much, or you don't notice it at all? You would say, yes, I do experience relief of my pain with distraction. Another sign that it may be brain. Do you have pain or symptoms or problems in other parts of the body? Remember, the brain as the CEO can create very real sensations and problems elsewhere in the body. GI issues, migraine issues, vertigo issues, other aches and pains in other joints. So if you have multi kind of body region or system issues, then you would say yes. Does your pain shift, spread, move around? Does it dance around for unknown reason? Maybe it was in the right thigh today, and then last month or yesterday it was in the left thigh. And sometimes it can be both thighs. And sometimes it's not in the thighs at all. That's weird. If you hit your right finger with a hammer, the right finger hurts. You generally don't say, well, one day my right finger hurt, and then the next day my right finger didn't hurt, but my left finger hurt. You hit your right finger with a hammer. So if it spreads, shifts, moves around, you're not really sure why. If you're sure why, then maybe. But if you're not sure why, then you say yes. Do you experience a delayed onset of pain? So you do something now, you go to physical therapy, you do some stretches, you mow the lawn, and you're fine in the moment, but then later it hurts. Again, when you hit your finger with a hammer, it hurts now and later. If you hit your finger and it doesn't hurt in the moment, then it hurts later, well, that would just be weird and it wouldn't make any sense. So if you have a delayed onset of symptoms, then you would say yes. Have you been given many or no clear diagnosis? If you've been given many diagnoses, well, then it means that nobody can agree upon what's happening, which means they don't know. And if they say, hey, your X-ray or MRI looks pretty darn good and is pretty darn clear, then again, you would say yes. Do you identify yourself as having a high pressure, perfectionist, people pleaser, type A, get her done, good student type of personality? Dr. Charlie, just give me the stretches to do right now and I'll do whatever it takes to solve my problem. If so, you are at risk for training your brain to experience symptoms. You would put yes. Is it hard to identify yucky emotions that clearly and consistently reproduce your pain? Meaning sometimes you do emotion, it hurts, other times you do emotion, it doesn't hurt, and everybody seems confused. That's not confusing. They just don't know what's going on. Could be brain. You'd say yes. Has there been a lack of response to physical treatment? If you're doing lots of things aimed at fixing the physical body and it's not working, then it's possible it's not the physical body. So, to wrap this up, if you answered yes to 7 or more of these 13 questions, then the likelihood is pretty darn high that your symptoms are, at least in the majority, of the brain. Again, not made up, very real, but we need to retrain the way your brain or central nervous system responds to the symptoms instead of just trying to fix the body. If you answered yes to 6 or less of these 13 questions, then it still could be brain, but chances are it's more of a structural issue with the body. And if you have not discovered it at this point, further evaluation and testing would be needed. So what I would recommend, go ahead, click below this video to download my Better Than an MRI DIY diagnostic guide. Once you figure out the source of your symptoms, know also that we help people all around the world dealing with these issues. If we went through this and this was helpful, let me know your thoughts. What did you discover? What questions and or insights did you gain from going through this? What is the cause of your front of your leg and or thigh pain? Thanks so much, everyone. Chat soon.